Welcome and thank you for joining today's webinar. This webinar is hosted by the Mortality Estimation Initiative, led by Save the Children in partnership with Evidence for Change and Impact Initiative. The initiative is funded by the European Civil Protection and Humanitarian Aid Operation, DGH ECHO, the UK Humanitarian Initiative Hub, UKHIH, and ELRA. During this webinar, we encourage you to ask questions using the Q&A function throughout the session. We are happy to provide live interpretation into French and Arabic for today's webinar. If you're interested in listening to the session in one of these languages, please click the globe icon that says Interpretation at the bottom of your Zoom screen and select your desired language. We'll also have some instructions in the chat. Today's recording and slides will be shared after the webinar and hosted on the Evidence for Change website. It is now my pleasure to turn it over to Laura Cardinal, Save the Children's Global Head of Health.
Thank you, Fasika. Good afternoon, good morning, and good evening to everyone who has joined us today. Welcome, and thank you for joining today's webinar, Why Mortality Matters in Humanitarian Crises, Principles and Concepts for Mortality Estimation. To help frame today's session, I'd like to briefly introduce the Mortality Estimation Initiative, which is one piece of the puzzle which is sitting behind the work we are discussing today. The goal of the initiative is to strengthen humanitarian programming by improving the timely collection, analysis, and use of mortality data. Mortality is one of the key indicators of crisis severity, yet in many humanitarian settings, it is poorly measured, inconsistently interpreted, or simply not available. This initiative aims to change that. We're working to ensure that humanitarian actors, whether global partners, national stakeholders, or field teams working in communities every day, have the tools, skills, and support they need to confidently integrate mortality estimation into their work. That includes operationalizing routine mortality surveillance, developing practical toolkits, strengthening national engagement, and building capacity through training and webinars like this one. This initiative is led by Save the Children in partnership with Evidence for Change and Impact Initiatives, and operates under a sector-wide multi-partner governance structure that brings together strategic, technical, and operational expertise with funding from ECHO and UKHIH. The initiative is focused on operationalizing mortality estimation approaches, piloting tools in real humanitarian contexts, and supporting stronger, more evidence-based decision-making. Ultimately, this work is about improving outcomes and saving lives by ensuring mortality data is used effectively and responsibly in crisis settings. And now for why we're here today. In this webinar, we will briefly explore why mortality estimation is such a critical component of crisis analysis and humanitarian decision-making. Mortality data helps us understand the severity of crisis, if urgent needs are met, and guides more effective evidence-based responses. Today, we'll walk through key concepts and indicators used in mortality estimation and discuss some of the common challenges we face when collecting, interpreting, and using mortality data. We're also fortunate to have input from our Evidence for Change colleagues who will share field-level perspectives on the practical realities of mortality data collection. Their insights will help connect the technical concepts with the challenges faced on the ground. Next slide, Fasika. And now I'd like to introduce our speakers. First, we have Andy Seal. Andy is an associate professor in international nutrition at the University College London and works on nutrition and public health in populations affected by humanitarian emergencies. He co-leads the Center for Climate Change, Migration, Conflict, and Health. His research interests include the epidemiology of malnutrition, optimization of food assistance and health interventions, and health and mortality surveillance systems. We are also lucky to have Mohammed Jelly with us today. Mohammed is the Executive Director for Evidence for Change, with over 15 years of experience in humanitarian programming and research in fragile and conflict-affected settings. He has led and contributed to operational research on nutrition, mortality estimation, and health system strengthening in the Horn of Africa. His mortality work in Somalia includes nutrition and mortality surveillance system and piloting community-based mortality reporting through family health workers, aimed at strengthening locally led mortality measurement in crisis contexts. Mohammed has a particular expertise in qualitative, participatory, and process evaluation approaches, and in translating implementation research into practical recommendations to inform humanitarian policy and programming. I'm so excited to hear from both of them today, and I hope you are too. I'll now hand it over to Andy Seal for our first presentation. Then we will move directly into Mohammed Jelly's reflections and then open it up for questions and discussions. Andy, over to you.
Thanks very much, Laura, and really great to have the chance to talk to people on the seminar today. So just going to share my slides.
We can see it great, Andy. Thanks.
Yep, you're good. Okay, thank you. Good. So today, we're going to do a couple of presentations to kind of set the scene for the future seminars in this series. And I'm sure a lot of what I'm going to talk about is extremely familiar, and I've seen that some of the people on this call were involved very much in a lot of work on this area. So hopefully it won't be too dull for those of you who've been working on this for some time, and hopefully it will still be useful for people for who this may be relatively new material. So the first question we wanted to talk about is why measure mortality in humanitarian contexts? So obviously the humanitarian imperative is about reducing excess mortality, suffering, and trying to preserve human dignity. And those are issues that we really can't address fully or know that we are addressing fully unless we measure the key indicators for these, including mortality rates. In the Sphere Project 2018, this is encapsulated in this statement here about the most useful indicators to monitor mortality, and the primary goal of the health response during crisis to prevent and reduce excess mortality and morbidity. So clearly, this is something we should be measuring if we are wanting to know what the problem is and whether what we're doing is solving the problem. Of course, it also has other potential uses. For example, to determine the impact of conflict and the consequences of political decisions. And so that kind of brings in the challenge in places that this sort of data is extremely sensitive and has a high potential political value, and therefore is prone to be contested and subject potentially to manipulation as well. So it's a very high stakes activity to engage in, but an extremely important one. So I just wanted to start off with a little bit of a history because, of course, none of what we're talking about today is new by any means. And we could go back to, say, ancient history to look at people's concerns about the cost of war and the impact of various conflicts on military and also civilian populations. We could jump forward, perhaps, and look at John Snow and his pioneering work in mapping cholera outbreaks and documenting mortality in London. And then perhaps another milestone would be, say, if we look at the single massive events in the Second World War, the bombing of the civilian cities of Hiroshima and Nagasaki. And even from those single events with very high profile, it's still extremely difficult to come up with an agreement on what the death toll was, even if it's just a single high profile event. In the 1960s and onwards, there was development of modified nutrition cluster surveys by INGOs and others, and mortality data started to be collected in a more routine way using more standard methods. And in the 1990s, there were papers by Toole and Wardman and others, which really elevated the issues of mortality and how much excess of mortality can be increased during humanitarian emergencies, and therefore the need to really understand the causes, to measure it, and to tackle it. The survey data was then compiled by initiatives such as RNIS and CRED, and that kind of provided databases, resources that people could go to and look at and understand by looking at a number of different contexts what the trends were and what was happening. So that, for me, I think was an important milestone as well. There were also development of these online databases which track the development of armed conflict and map casualties, and that made, again, the issues more transparent. And then from 2002 onwards, the SMART initiative helped to develop standardized or further standardized nutrition and mortality survey approaches. And then we had to make really high profile studies done in Darfur during the suspected genocide. And then during the Iraq invasion, mortality studies that were done then received a huge amount of political attention due to their profile and the situation at the time. More recently, we've seen trials of new approaches using satellite image analysis and capture and recapture techniques. And then perhaps the last point which I've added is that we're currently in a situation where there's been a collapse in humanitarian funding, and therefore the resources available to measure and document what's going on have been greatly reduced. But that also kind of implies that we really need to know what's going on if we are trying to allocate scarcer resources for maximum impact. So that's kind of a historical view. If we look at what we're trying to measure, I'm just going to sort of expand this chart just to try and illustrate that when we talk about mortality during emergencies, especially during conflict, we are often talking about different things and may not realize we are. So total casualties sometimes means mortality only, but of course would also include morbidity and injuries as well, if we used it in a more careful way. And then within those categories, we have direct and indirect deaths during a conflict. And we also have issues around excess mortality and baseline mortality. And again, it's sometimes difficult to determine when people are talking about mortality, which exactly are they referring to. And then, of course, in direct conflict, we have combatants and civilians. And again, those issues are sometimes not made clear or can be quite confusing to understand whether people are talking about total mortality or only that of civilians or combatants. So unpacking exactly what we're collecting is really important, I think, and understanding what those different categories are useful for. So these are just some of the key papers. So just to reiterate, what we're talking about today is nothing new, and people have been working on this for decades now. But despite all of this effort by a wide range of different actors and people, we are still failing to always produce timely or precise estimates of mortality. And therefore, more efforts need to be made. The momentum needs to be accelerated if we are going to achieve the aim of having reliable mortality data available for decisions and accountability. So just to quickly look at some of the indicators that are routinely used. So the top two are the ones which are perhaps most widely used and referred to: the crude death rate, sometimes called the crude mortality rate, and the under 5 death rate, sometimes called the under 5 mortality rate. But there's, of course, a range of other indicators that are readily, or sometimes readily available, including the child mortality rate, which is different from the crude death rate and the child death rate, the age standardized death rates, case fatality rates, maternal mortality ratio, et cetera, et cetera. So a range of different indicators may be available, but the ones that tend to get most attention and tend to be measured most often in humanitarian contexts are the crew death rate and the under 5 death rate. Thresholds, of course, are needed if we're going to interpret any of these indicators and make decisions. So is this a rate or ratio which is normal and within the normal range in that population, or is it excess mortality attributable to a particular event or emergency? And the thresholds used can be fixed or relative, but the most widely accepted thresholds are those which are fixed. So for the crew death rate, it's 1 or 2 deaths per 10,000 people per day. And for the under 5 death rate, it's double that because of the higher baseline level of child mortality. Of course, there's a huge debate ongoing about whether these are correct to use, whether they should be adapted now, as these were developed many decades ago now, based on higher baseline mortality at that time. We also have the issues around demographic transition and demographic change, which means that crew death rates tend to be higher in higher income countries just because of the demography of the population. So a lot of issues around mortality thresholds, but currently these are the ones that are most widely used. And whether or not a particular threshold is crossed is important in helping define the severity of humanitarian situations. For example, in classifying famine by the IPC or other stakeholders. So when we're collecting data, of course, there's a number of methods that can be used, and these are, from my perspective at least, ranked in more or less preference order. So some countries have vital statistic registration systems, and they may still be functioning well in a war situation. But often we're going to be relying on household survey data or graveyard counts. And then after that, we kind of move into areas which perhaps have more technical challenges and are more prone to bias, such as telephone interviews, which I'll talk about a little bit in a second, satellite image analysis, capture, recapture studies, and of course, there's interest in using crowdsourced social networks information to try and come up with estimates. But of course, that perhaps of all of these is the most prone to bias. So in terms of using telephone interviews, I just wanted to talk about one experience that we had during the COVID pandemic in Somalia, where there had been a regular house-to-house survey. And after COVID kicked in, we had to move it to telephone-based interviewing. But we managed to capture quite a lot of data from a wide range of clusters in Somalia, indicated by the blue dots on the map. And then by using a longitudinal approach with regular interviewing of the households by telephone, we were able to come up with estimates of the CDR, U5DR, and also a specific case fatality rate, or cause specific to COVID. So that was an interesting experience, and other people, of course, are using telephone interviews as well. But of course, one of the big problems with telephone interviews is that people don't answer the phone if they've been killed. And so therefore, it's particularly prone to bias in mortality estimation. So it'll be interesting to see if approaches can be found which will help to mitigate that. And one of those is the approach we used here, which is to use longitudinal data rather than relying on cross-sectional surveys, as that allows you to look at the sensitivity of your estimates. Okay, and another approach, of course, is to use mortality modeling and projections. So there's been some really interesting work recently in terms of the 2011 and 2017 emergencies in Somalia, retrospective estimates were modeled. And then in Gaza, there's been projections of likely mortality based on various different scenarios. So scenario modeling to come up with a range of possible mortality estimates. So those are sort of cutting edge, and I'm sure we'll probably hear more about those types of methods in future seminars in this series. It's good to flag, just wanted to flag them up here. Now, of course, whatever method we're using, data availability can be and often is a challenge. And there are many situations where data availability is limited. And that's, of course, one of the key themes that Laura talked about at the start and why this project is going forward. So I just wanted to look at 3 examples. So this was the famine in 2011 in Somalia. And in this particular case, it was possible for the IPC to classify famine using survey data. So at that time, there was actually quite good survey data available, including mortality data, retrospective mortality data from these areas, which allowed a famine classification. It was after this that I then joined the Famine Review Committee and have been involved in a number of different reviews since then. And our experience has been that we now really, very rarely have good quality mortality data. So in 2 recent reviews, so from Sudan and also Gaza, we really didn't have a lot of good quality survey data that was timely and allowed us to make a classification. And this, I think, is something that we are probably going to increasingly see, one, due to the political sensitivity of collecting this data, and therefore the security implications of doing so. And secondly, because of, as I mentioned before, the collapse in humanitarian funding means that there are just fewer resources available to attempt to do this. So that, of course, is leading to a lot of challenges moving forward and is leading to discussion. So the lack of availability of gold standard mortality data is arguably one of the reasons why people are discussing, for example, whether mortality should be included in, for example, famine classifications. And if it is, maybe the actual thresholds need to be changed because it's just perhaps regarded now as too late an indicator. So partly it's due to the lack, I think, of availability. Partly it's due to the changing nature of baseline mortality and the issues of demographic change. But these factors, I think, coming together to create a lot of debate about where we should be going in terms of threshold and even possibly not including a mortality analysis for some classifications. Now, moving now from the actual measurement of mortality rates to death, causes of death analysis, which also, of course, is really important. And so for this, a number of methods are available. So one might hope there would often be physician reports or post-mortem autopsies, but often these would not be available. And therefore, approaches such as verbal autopsies or just categorization using survey tools is often what we have to use. I just wanted to quickly give one example of where we've done a study using verbal autopsies. So this was in the Afgoy corridor near Mogadishu in Somalia in 2017. So here we see the timeline from April 2016 through to March 2018. And in red, we have the under 5 death rate, which you can see from the right-hand axis exceeded 2 and 4. And it was extremely high from about April 2017 for about 3 months. So this was an interesting example, and we were able to document this using longitudinal nutrition surveillance and mortality surveillance, which Jelly will talk about a little bit in a second. And the bit that we added to this was actually use verbal autopsy to try and determine the cause. So this graph shows the mortality fraction that is attributable to each of those causes, which are shown in different colors. And from that, we could see a number of things. One, there was, unsurprisingly, a measles outbreak, which caused a lot of mortality. Also, it's important to note that there were, it was increasingly difficult, of course, to ascertain or conduct all the verbal autopsy interviews that were required during the peak of the emergency. So there was an increase in the unknown causes. But nonetheless, this was, we felt, useful exercise to document longitudinally in a population the death rates and the causes of death, and showed that at least in some situations it could be done. And of course, the usual suspects came out, unsurprisingly, with diarrheal disease, severe malnutrition, measles, and malaria being in the top. But it was interesting to see how those causes of death changed between the protracted emergency and the emergency influx phase that we looked at. I just wanted to flag those examples up. So in conclusion, before I hand over to Jelly, I'd like to argue that mortality estimation is a core part of the humanitarian mission and essential for monitoring impact. Ensuring timely data collection is carried out is extremely challenging and sometimes impossible for a range of factors, and therefore further initiatives to improve the methods available and how we do this and how we interpret the data are very much needed. And lastly, important to note, of course, that if you look at any data, it's not just mortality data where there are gaps. And so hopefully efforts to strengthen mortality data may help in strengthening other types of data, for example, food security and WASH data, which is also very badly needed. So I'd like to stop there and hand over to Jelly. Thank you.
Okay. Thanks so much, Andy. And hello, everyone. Good afternoon. What I'm going to do is today also to add on what Andy has just presented and talk a little bit about and reflect on the challenges that we face when we are collecting mortality data in the field. And as I do that, I will be drawing on two examples. One is the nutrition and mortality surveillance that we have been doing for a while now in Somalia, at least since 2017, and a new initiative, which is setting up of community-based mortality surveillance embedded within government-led and World Bank-funded female health worker program that is happening in Somalia. Next. Good. So if we start with operational challenges, the first one is, for example, in places like Somalia, if you're doing mortality data collection, most of the time you would focus on areas that are quite accessible because of security reasons. So in most of the areas that are non-state actors controlled, you would not be able to collect data. Another one is population displacement. So especially if you're on our nutrition and mortality surveillance solely focuses on among IDP communities. So population displacement is quite an issue because what we also use is longitudinal data collection, and we conduct every iteration, we conduct several rounds of data collection, and that is an issue. Another thing is also the fluidity of the household structures. Those of you that might have worked in among IDP communities, you would see that in the households are quite not very stable. They might split. They might new members might come and join or leave the household, and then you might also find that sometimes, because it's also a way to diversify their income, they would claim that households that are already living together are not the same households, and they would claim that they are not from the same households. Another potential problem is the reliance of recall, and many people will not even remember when, for example, a death occurred. Remember, we're talking about a setting where, for example, death is a scarce event, but it might not be that scarce. In a year, maybe family might have experienced one or two kind of deaths, and they might not primarily remember when that kind of a death happened. Stigma is also another issue that certain deaths are not preferred to be reported because of stigma. So, for example, if somebody died because of HIV-related death in Somalia, they might not necessarily report that. The opposite of that is also true, where sometimes they might over-report death and exaggerate, mainly because they think that by doing so, they might get humanitarian assistance. And another related issue is enumerator performance. Sometimes you might train the several enumerators and supervisors, but their performance will be different. And then when you tell them to go and collect the data, if you are checking regularly the data that they are submitting, you will find that maybe one or two of the enumerators are reporting a bit higher number of deaths. And in that case, then you need to put in place a mechanism you would be able to verify the kind of deaths that they are reporting. Next. So this is, for example, the steps that we take in our nutrition and mortality surveillance. And what I would like to mention is there are about 6 to 7 different steps. And one of them, after the data collection is done, is that we have the verification step, where if certain enumerators have reported high number of deaths, then we would have this step where we would have specific enumerators that are a bit highly skilled, that are given special training, will go and will verify whether certain deaths might have happened or not. Next. And just to give you a bit of a glimpse of what we're talking about when we talk about an IDP in Somalia. So this is a picture of an IDP camp in Mogadishu Abgoy corridor, and you can see how close the settlements are, and this is what I've been talking about when I was talking about the fluidity of the household structures. So you wouldn't be able to differentiate two households that are near to each other if they tell you they are from different households. Next. And this is just to give you a bit of a feel how this looks when you use satellite imagery. And this is one of the camps that we have been working in Kismayo, and you can see even from this image, you could feel that this is, yeah, it looks like a typical IDP setting in Somalia. Next. And this is also another one. And as you can see, you sometimes you get the one that I showed you a little bit earlier. And then sometimes this is what you get. You can see large settlements, probably host communities, and then among them scattered are some IDP households. Next. So to continue now, we will also look at the political and ethical constraints. So mortality data naturally, as Andy mentioned, can be politically sensitive. So there should be some sort of care that needs to be taken when collecting, when planning, and who also needs to be informed about it. And there's also the risk of pressure on local institutions that are doing data collection. For example, if IFOC is the one that's leading, compared to if, for example, international institutions were doing, and the risk and the scale of repercussions sometimes might be a bit quite different. Whereas international organizations, they might, the worst case scenario, they might be BNG'd and they might be told to leave the country and they may withdraw their certificates. I mean, the local institutions, that might, it might not stop there. It might even be the individuals who are working for those institutions might be targeted. In addition to that, there are some ethical concerns sometimes, especially certain deaths. So if you are collecting mortality data and you are informed about certain deaths, what do you do about it? How do you handle that kind of other referral systems that you can refer to the bereaved families? That is also something that need to be thought about. And then, as I mentioned earlier on, communities are quite vulnerable, especially among IDP communities. And when you are collecting data, what you need to do is you need to manage expectations, because the moment you ask questions that are related to deaths of family members, then they would relate that to certain type of humanitarian assistance. And sometimes you might not even have the ability to provide those assistance, and all you want to do is to conduct your survey or collect the data. So there is the risk of creating expectation when you cannot meet that. Next. Just to continue also, and as I mentioned, this is the not only although my experience is drawing on our work in Somalia, but I think based on the different consortia that we are members on, this has been the case that mortality studies, funding for mortality studies, most of the time short term, and it lacks a bit of sustained efforts. And sometimes there might be coordination that involves multiple agencies. For example, the nutrition and mortality surveillance that we're doing with different organizations in different areas. Although we are working with one consortium, we're working with consortium members. So in Kismayo, Baitabo, Mogadishu, and Dolo, where we're doing at the moment that work. In each of those locations, we work with a different NGO, and that needs coordination, and it's not that easy. It sometimes might be a bit of quite a pain to handle. And then there are also sometimes duplication of efforts. You might find several different organizations doing the same thing or similar thing, and there might not be willingness to collaborate. And we have experience in our case in Somalia, where another organization and Evidence for Change were doing similar surveillance systems, community-based mortality surveillance on the ground, and we wanted to collaborate, but a certain donor did not want that to happen, saying that they want ownership of what was done. So that also happens quite often, I think. Next. So what is next? So just few points that I wanted to throw as recommendations. So I think given that it's not that easy to collect mortality data on the ground, it might be good that we build local leadership, local capacities, and it's the process is locally led. As far as possible, maybe integrate mortality into routine systems. And to do that, we will need also to simplify and standardize tools. And one of the objectives of this, the mortality estimation initiative, is to do that. And then also, as we do that, we also need to protect the independence and transparency of the work that we're doing. And lastly, also try to invest in sustained systems and not one-off surveys, as is the case at the moment. I'll stop here. Thank you. And we will have, I think, session for question and answers. Back to you, Laura and Fasika.
Great. Thank you so much, Mohammed and Andrew, for your presentations. We have about 15 minutes for discussion and question and answers, and I see some questions are flying in. So let me just pick a couple and share them with you. So one is, in politically sensitive crises, who should own mortality estimation? And what safeguards, governance verification, funding models, etc., can prevent data blockage or manipulation and ensure uptake in decision making? Jelly or Andy, this is for either of you to answer. Andy, I see you've come off
Shall I
mute.
have a bash?
Mm-hmm.
I mean, I think every situation requires political economy analysis of who are the stakeholders and what are their agendas and potential conflicts of interest. So obviously the parties to the conflict, but also the national, regional, international backers. So you need to really map out who's involved and what is at stake for those different stakeholders. And then that should inform, I think, the decision about how the data collection is done, and allow you to try and put in safeguards to protect its neutrality and independence. I think you need to do that in every situation, unfortunately, I think, because every conflict, assuming this is a conflict, of course, situation, every conflict will have a different set of stakeholders with different agendas. So trying to understand that, I think, is the first thing. And then secondly, looking at how you can try and position data collection and analysis and dissemination to try and be neutral and independent and perceived as far as possible by the different stakeholders as that. Now, it's unlikely, of course, that the parties to the conflict or those with direct interests are going to agree that whatever you do is good enough. But that's, I think, the starting position to go with.
Thanks, Andy. And maybe a follow-up question of, what do you guys think could be done at the national level to engage different entities so there is more acceptance of mortality data to be used, to be uptaken, to be used for decision making and transparency?
Should I go with that, Andy? Yeah. I mean, in the case of Somalia, where I'm drawing my experience, there has always been willingness to engage, to listen, and partners, not only the humanitarian actors, but also the governments, both the federal member state as well as the federal government as well as the federal member states have been quite willing to listen and support the initiatives that we have been doing. So I think what needs to happen is that at the beginning, we need to involve people in whatever we are planning to do. My experience is that people always feel a bit not willing to collaborate and support certain initiatives if they happen to be involved after things have started. So if you consult them and if they feel that they have a say, you involve them from the design, I think most of the time they listen.
Thanks. Thank you, Jelly. Sorry, I'm just trying to read the other questions. There's a question from Saeed, Andy, on how could we improve our cause of death analysis in normal mortality survey or surveillance methods without having to implement a full verbal autopsy. He's saying it's quite limited right now, but there must be some way to make a good enough attribution to things like malnutrition, outbreaks, etc.
Yeah, I think obviously, say in a standard smart survey questionnaire, there'd be categories of death which the respondent will be asked to select from. So that can help get us a certain direction. I think one of the sort of the conceptual problems with causes of death is that people often assume there's a single cause, where often there are multiple causes. And the advantage of a verbal autopsy approach is that it allows multiple causes of death to be counted in the triple fraction. And that can give you a much more accurate view, I think. For malnutrition, for example, it's often an underlying cause or a contributory cause, even though the immediate cause of death might be a measles infection or something else. So by using that type of approach, it allows you to capture the more accurately the overall contribution of different causes to the death rate. However, yeah, that does involve a lot more work than a simple questionnaire. And although it was surprisingly quick, I think when we did that, we were lucky to be working with very good enumerators in Somalia when we did that. I'm not sure, Jelly, if you wanted to comment at all on how feasible you thought that was in that context.
Yeah, thanks, Andy. Yeah, just to start with, Wendy, first, if I remember, we used the WHO bubble autopsy tool 2016, if I remember very well. And one of the things that we did, and Said, I think you were asking how that could be used in humanitarian setting because it's long, and I agree. But what we did was we adapted the tool, and some of the questions that are not very important for classifying the probable cause of death, we were removing them. So, for example, a lot of questions related to the demographics, I think we removed them. And then in addition to that, what you also need to do is you need to, I think verbal autopsy is one of the questionnaires that you would need to try to be quite very selective in the type of enumerator that you're going to send. So they do not necessarily you do not necessarily want somebody who would go and just ask the questions, yes and no kind of a question, but somebody who is quite good in probing and building rapport with the person. And in Somalia, that's what we had. Although that was the first time that they were doing after training, I think they picked quite well, and I believe in many settings that could be the case. So what you need is yes, fluency in reading the questionnaire, but they should have the capacity to be able to probe and build rapport with the person.
Perhaps one other thing, I think as with anything else you might be trying to measure in a questionnaire survey, it comes back to good training and supervision and getting the questions right and making sure the translation is correct. So the basics, I think, will really help in improving the quality of mortality estimation data or cause of death data, as well with other things. So I think a lot of it just comes back to the basics of trying to run a good survey.
Great, thank you. And Jelly, maybe one for you to start with. There's a question in the chat about how have communities responded to the results, interpretation, and subsequent use of mortality data collected in past exercises from them. Based on your experience, what could be done differently to strengthen community engagement, understanding, and positive impact of collecting this data?
Yeah, good question. I mean, I would say normally communities, when you feed them back, it depends how you do it. If you're doing that as a group and you're feeding them back as a group without necessarily pinpointing what is specific, for example, family's death was related to, then that should be fine. I think that would be quite okay. So if you're saying, okay, many of the people died, or many of the children, for example, died, measles, of malnutrition, they would be quite receptive. They would be quite okay with that. Now, the tricky part would be in places like Somalia when you tell them, okay, some of them died also HIV-related deaths, and then they would be okay. Okay, who are we talking about here? And there may be a bit of suspicion. So that is the ethical dilemma of now how you also feed back that kind of information. Do you feed them back? Do you just withhold that kind of information? And we're not talking about just a bit of curiosity here and there. We're talking about big suspicion amongst themselves. Okay, whose child is the one who died of HIV-related death? Where did they bring it from? Is it really true that they died of it? So that's also now thinking a bit about the data that you collected and if what you are sharing with them is actually true. So I think probably what you also need to do is you need to tell them, okay, what we did is bubble autopsy. There's relative degree that it's a probable cause. It's not 100% correct. But I think in most cases they would understand. They would listen. What I found, especially when we did that bubble autopsy work in Somalia, was the engagement that we had with the government, because compared to the national levels of HIV-related deaths or the prevalence of HIV in Somalia, the deaths were a bit higher. And what the government officials were saying is, well, it's fine. I mean, they were not quite worried about it. So that was quite positive, because we were worried that they would react a bit badly and they would have a lot of questions that we might not answer, but that was not the case. Yeah. I think there was a second question of, the second part of the question, could you say that one more time?
The second part of the question was, based on your experience, what could be done differently to strengthen community engagement, understanding, and the positive impact of how this data can be used? But I think you might have gotten to some of that, but please go ahead.
Yeah. I mean, with the NMS, it was the nutrition and mortality surveillance that we did. It was a bit different. It was top-bottom kind of approach where we designed and then we involved the community later on. But with the new initiative that is using the female health workers and working with the catchment areas where they work, it's a little bit different. So we're working with the community members, so the female health workers, the supervisors are part of the community, and we are starting with them. So before even they start data collection, they might have some interaction with the communities, tell them about the kind of work that we're doing. And I think we also had a bit of smooth data collection when we started the data collection, primarily maybe because of that.
Great, thanks.
So
thank you. Engagement. Thanks, Jelle. Thanks. Andy, over to you for a question from Adrian. And I think it's to expand a bit on the discussion you started during your presentation on the debate around using mortality estimation for famine declarations and famine reviews. So she's saying mortality is arguably the most significant metric in IPC famine reviews, yet it's frequently missing. How do you safeguard the credibilities of reviews in this absence? And how might reliable mortality data change the classification process decisions? I don't know if you could expand a bit on what you were talking about earlier to respond to this.
Thanks. I think the last bit's easier. If there was more reliable data, it'd be easier to do, to make the classification. So that would be straightforward. But in terms of, for example, if we look at the Gaza famine classification, then that was made with reasonable evidence because we were missing reliable evidence on mortality. We believed that the thresholds were exceeded, but we did not have the good quality direct data to show that. So therefore, the famine classification was made primarily on the basis of the 2 out of 3 outcomes, which the IPC protocols allow to happen. So it was famine with reasonable evidence, which in previous iterations of the manual would have been called famine likely, but it's now called famine with reasonable evidence. So that's how we dealt with that particular situation. I think in general, it's clearly a problem, and therefore other sources. So we looked at all the available mortality information that we could find, whether that was records from the MOH or whether that was surveys that had been done, but had been done at kind of different times. So we had to then try and think about now casting that data to what was happening at the current time. And another point is that the IPC uses convergence of evidence, so pulls together all the available bits of evidence and indicators to try and understand the whole picture, because frequently we will likely be missing a key piece of data on a particular indicator. So the conversion of evidence approach allows the painting of a whole picture using all the available data sources. So I'm not sure if that was a really good answer, but it would be lovely if we did have reliable mortality data from the current classification we're trying to make. It would be super useful.
Thank you. Thank you, Andy, and thank you, Mohammed Jelly, for all of your thoughts and for sharing all of your expertise and for kicking us off on the first of what is going to be a webinar series hosted by the Mortality Initiative. We're really excited to have you both and appreciate your time and sharing all of your insights. And apologies, we weren't able to get to all of the questions, but we will review them and work on some answers for when we send through the recording. I want to thank everyone for coming today. Just a few quick things before you sign off. First, I would like to encourage everyone to go and visit the blog series that has been published by UKHIH. I've put the link in the chat here. There have been 3 blogs published so far, and a blog from the Mortality Estimation Initiative will go live tomorrow. So please do check out that blog series. I would also encourage you all to join the Mortality Estimation and Localization webinar at HNPW next week on March 10th. That will be at 11 a.m. Eastern Time. And I think Fasika will put the link, thank you, Fasika, to register for that panel discussion at HPNW next week. And finally, I wanted to encourage you, if you are interested in learning more about the Mortality Estimation Initiative, are interested in joining and sharing your expertise at upcoming events or webinars, want to hear what we're up to, or join a potential future community of practice, please do join our mailing list. We are just getting going, and this is sort of our inaugural event in some ways. So again, a huge thank you to Andy and Mohammed Jelly for joining us today, and for Evidence for Change in their leadership for planning this webinar, and of course to ECHO and UKHIH for funding this initiative. Thanks everybody, and I hope you have a wonderful day. Thank you.